Hello, my name is Jeanette Domask, and I am a risk manager at OMIC. And our presentation is Anesthesia Liability and Ophthalmology. This is a frequent inquiry that we receive from our insured surgeons, and we hope this is helpful in understanding exposures in your respective practices. So the focus of this presentation will be on various anesthesia considerations, the legal framework and regulations that surround settings we perform surgery, and also the anesthesia providers that you work with, some common liability issues when you as a surgeon are brought into litigation with involving anesthesia, some case examples, and then some risk management recommendations. So the anesthesia considerations, location of the procedure is a top one. It could be hospital, ambulatory surgery center, or an office-based setting. This presentation will focus on an ambulatory surgery center and office-based surgery. Various anesthesia providers include anesthesiologists, CRNAs, RNs. There are some supervision requirements for non-MD providers. Patient selection criteria as to where you're going to perform the surgery. The type and level of sedation is a consideration. Who's going to monitor the patient, pre and post procedure instructions, and then an emergency response plan. So we'll go over these various considerations. So first, the location of the procedure. Obviously, you can have a procedure using anesthesia in a hospital setting. We will not focus on that during this presentation, but an ambulatory surgery center is what we'll focus on along with office space. So ambulatory surgery center is licensed and accredited, and they typically will follow the Medicare conditions of coverage. There are 4 accrediting agencies in the nation that provide that credential for ASCs. Office-based surgery, they may have little or no regulation or oversight. It depends on the state. So every state has different laws. Some don't have any actual regulations. Some have more restrictive regulations, and some require an accreditation just like an ASC. So they're all different. So an ambulatory surgery center, it is a medical facility that provides surgical care for patients who can be discharged on the same day. There are state-specific licensing requirements, and then there's also Medicare requirements for certification. And these requirements are usually met by obtaining accreditation by one of the 4 national accreditation bodies. And they usually follow the Medicare accreditation because most people, most facilities take Medicare. So those ASC accrediting standards are closely aligned with the Medicare requirements, which are called Medicare conditions of coverage. They're under the federal regulations, and the Code of Federal Regulations that we'll be specifically discussing are Title 42 CFR Part 416. So in an office-based surgery, this shows about half the states have state laws that regulate procedures in the office setting due to the use of sedation, and the Federation of State Medical Boards tracks the state-specific statutes, and they do keep pretty up to date. This is a good resource to look at when you're investigating what the regulations are for your particular state. Some states do mandate accreditation, just like an ASC. Others, you register with the state health department, and they do the regulation, the state health department. Some states designate that the licensing falls under the physician's medical license. Some states are silent and have no regulations, but the states that do have laws, they guide the scope of practice of respective staff that are involved in the office-based surgery, the safety of the procedure, administration and monitoring of sedation, and then emergency plans. So they make sure that you have an emergency plan, emergency equipment, and a transfer agreement with a hospital. So next, anesthesia. providers, this is obviously another big consideration. We are going to focus on CRNAs and RNs, because that's where we get the majority of our calls when there's concern about supervision of a surgeon of a CRNA or an RN. But I do have case examples with anesthesiologists, and anesthesiologists also can potentially expose the surgeon to liability when there is an anesthesia event, and we'll get into the details of that. But the various anesthesia providers, obviously the anesthesiologist, who's the physician, the CRNA, who is a certified registered nurse anesthetist, and by 2025, all new CRNAs must hold a doctoral degree to practice. So that's by 2025. Registered nurse. Majority of states do allow registered nurses to administer anesthesia. So we'll talk about that. And then sometimes the surgeon is the one that administers the anesthesia, or there's a non-anesthesia provider. Another type of provider is an anesthesiologist assistant. Most states don't recognize this. I use this example because the Medicare Conditions of Coverage talks about this type of provider. 22 states or 21 states do recognize AAs under their state law, but they are under the supervision of an anesthesiologist. So this slide shows the CRNA scope of practice, and this again is based on state regulation. They also dictate prescriptive authority. That's also determined by state regulation. So some CRNAs can practice independently in some states. So the first slide with the light blue and dark blue states, this shows states where CRNAs can practice independently. And there is some sort of physician oversight in the dark blue states. Sometimes it's a collaborative agreement, or sometimes there's other conditions of practice. But in the light blue states, CRNAs practice independently. They don't need to be supervised. Now the second slide is focused on CMS and opt-out. So in 2001, CMS changed a federal law regarding physician supervision of CRNAs by allowing states to opt out of the requirement. So in states that have opted out, physicians do not have to supervise the CRNAs. In states that have not opted out, the surgeon has to sign a supervisory agreement. So as you can see, the maps sort of line up with the independent CRNAs are also the states that have opted out. So the green states have opted out of the federal requirement requiring supervision, and the light blue is also independent. So they sort of match up, but there are some states, if you look at North Carolina, they have not opted out, but their CRNAs can practice independently. So these are two different regulations that to be aware of when you are working with a CRNA. So registered nurse, again, most states RNs can administer sedation, or they're silent as to any scope of practice policy regarding nurses administering sedation. The only state that I found that you cannot administer sedation as an RN is Utah, and they can only administer sedation if the patient is intubated. So the administration of medications, including anesthetic agents, is typically within the scope of practice of a registered nurse. They would be under the supervision of the surgeon. We would recommend ACLS certification for the RN. The RN scope of practice is defined by the Nurse Practice Act in each state, and there are no national credentialing and privileging standards for sedation administration. The National Council for State Board of Nursing is a good source to look up your respective state laws concerning administration of anesthesia by registered nurses. But again, there is no actual national standard about RNs administering sedation. So we've seen it for years in the office-based setting. That's typically who I've seen administering the anesthesia in office settings in the state that I handled litigation in, and that was in Arizona. You're also hearing about it more in ASCs when there's a reduced amount of availability of anesthesiologists, when there's not enough CRNAs, or they're just trying to control costs. ASCs are now using registered nurses to administer anesthesia. And so we get calls about that as well. So to focus on the ASC regulations that CMS sets, these are all the different categories regulated by the Federal Code of Regulations for ASCs. We're going to focus on surgical services because that's where anesthesia falls under. So under surgical services, the ASC regulation is before a procedure, a physician must examine the patient to evaluate the risk of the procedure, and then there must also be an evaluation of the risk of anesthesia. So those two things need to be done. There also should be discharge criteria that involves respiratory function, cardiovascular function, mental status, temperature, pain, nausea and vomiting, and post-op hydration. So those all should be addressed before a patient's discharged, and there should be a set policy and procedure about the criteria. So this all falls under that Code of Federal Regulation for ASCs. Another part of the Code of Federal Regulations involves the administration of anesthesia. So the anesthetics must be administered by only the following. So they list anesthesiologist, a physician qualified to administer anesthesia, a CRNA, an anesthesiologist assistant, or a supervised trainee in an approved educational program. A registered nurse is not listed on this, but it goes on to say if a non-physician administers the anesthesia, which would be a registered nurse, then the anesthetist must be under the supervision of the operating physician. So anytime you have an RN administering the anesthesia, and you're the surgeon, they are under your supervision. So you can be held either directly or vicariously liable for their acts or omissions. That's just something to be aware of. An ASC may be exempted from the requirement for physician supervision of CRNAs. So that's what we discussed before. In the states that have opted out of that federal requirement, physicians, surgeons do not have to supervise the CRNAs. In some states, they do. So that's another layer of potential liability exposure. To go over liability exposures that surgeons might be exposed to when they supervise CRNAs or RNs administering anesthesia, they could be held liable for their acts and omissions. ASCs, the actual facility, can also be found liable for negligent hiring, negligent training, negligent credentialing of staff that's either employed or contracted by the facility. So that's really important to make sure that you have strict credentialing procedures. Every state does have different statutes, different case law, and scope of practice guidelines that would be applied depending on the specific facts and allegations in the case. So to mitigate anesthesia liability in any setting, surgeons should definitely focus on what's within their control, such as patient selection. So oftentimes we'll have a case, there was an anesthesia event, the anesthesiologist is named for their scope of practice or standard of care violations, but then the surgeon gets named because the patient selection wasn't appropriate for that setting or for that level of anesthesia, and they get brought in. So they're not directly responsible for the anesthesia, but they end up being responsible because the patient had an adverse event from the anesthesia because they shouldn't, maybe they were in ASA 3 and should have had the surgery in a hospital versus office-based setting or an ASC. So surgeons really need to use their best medical judgment concerning requirements that are imposed for supervision of non-physician anesthesia providers. So to ensure the competence of CRNAs and RNs, really should discuss with the ASC administration their policies and procedures for credentialing, privileging, and training of the anesthesia providers. Any competency concerns of those providers should definitely be brought to their attention immediately. It would be recommended to use a separate informed consent form for anesthesia to help delineate responsibilities and scope of practice. So with the various allegations, you can have improper pre-op assessment or patient selection. And with something like this, if there's an anesthesia event, the surgeon could also be brought in because the surgeon is responsible for the pre-op assessment or patient selection. Improper anesthesia administration, that can be only on the anesthesiologist, but say you have an RN that's under the supervision of the physician, and if they administer the anesthesia improperly, then that liability could also fall on the surgeon. There could be inadequate monitoring of the patient that leads to an anesthesia event and potential claim. A failure to recognize or treat complications that occur, improper response to emergency, and we do hear about this frequently where there is an emergency and the staff is not familiar with an emergency response plan, and that leads to a delay in treatment, delay in resuscitating the patient, and then failure to resuscitate. So standard of care. The standard of care involves a duty owed, a duty breach, and the breach being approximate cause of the damages. So when there is litigation, the duty owed is based on the respective specialty of the provider. So an ophthalmology surgeon, their standard of care is what another ophthalmologist, a reasonable and prudent physician with similar background and skills and education would do under similar circumstances. So an ophthalmologist does not have the same standard of care as an anesthesiologist. But if they're supervising a CRNA or an RN, they could be held both direct or vicariously liable for the acts or omissions of those providers. So it's important just to be aware of liability exposures and then focus on what you have control over and can do to mitigate those risks, which, as we discussed, include proper patient selection, having criteria. If you have an ASA 3 or 4, are you going to send them to the hospital and not have the procedure done at the ASC, for office setting? make sure that the patients that you're seeing in an office setting doing procedures have, don't have sleep apnea, high BMIs, things like that. So establishing criteria is the most important thing that you can do up front, and taking the proper history and that sort of thing. We'll get involved into that a little bit more. So this was a study that OMIC did with cases from 2008 to 2018. There were 63 anesthesia-related suits. And as you can see, the majority of these injuries involved globe perforations. So due to the regional nerve blocks like retro or parabulbar anesthesia, that was the majority of the injuries. The second most common was death. And death was reported in 13 cases out of the 63. All but one patient who died had significant pre-existing conditions. So as you can see, patient selection is very important. Brainstem anesthesia occurred in 2 cases, and that was from a retrobulbar anesthesia nerve block. And then 4 of the 13 deaths involved general anesthesia. So nerve blocks are the most common injuries, and ones that anesthesia providers need special skills to provide. These are usually done by the ophthalmologist, but sometimes they are done by anesthesia providers. And I have received calls from panicked anesthesia providers in prior carriers who caused either a hemorrhage from administering a block, and then saying that they weren't familiar with these type of blocks. So it's really important that your anesthesia providers are well versed and well skilled in these ophthalmology blocks, because they are not ones that they might do frequently. So again, credentialing and privileging is very important. So as went over, the areas that the surgeon can focus on to reduce risk include the patient selection, pre-op assessment, getting a full history. We were having a case years ago where a patient didn't tell a provider that they were, or surgeon, that they were on the transplant list for a new liver. And so he had cirrhosis of the liver, and it just never came up in his pre-op history. He never told the surgeon about it. Surgeon wasn't aware of it, and then there was an adverse event. So it's really important to get that history from the patient to be able to evaluate whether or not they would be a good candidate in the ASC or office setting. Another area is sedation type and level, and less sedation oftentimes is better. And there are, cataract surgery now, they're just doing topical and local anesthetic instead of moderate sedation. Anesthesia administrator credentialing, that's really important. The providers that you use for anesthesia should have really strict credentialing and privileging at your facilities, whether it be ASC or office setting. And then an emergency response plan. Years ago in Arizona, there were no regulations. It was around 2008. There was no regulations for office-based surgery. So there was a surgeon that was doing cosmetic procedures in his office setting, and EMTs were called out twice to help resuscitate a patient. So this surgeon's emergency plan was to call 911, and it's not a good plan. You can't do that. He ended up killing 2 or 3 patients over the course of a few months, and the EMT ended up reporting this surgeon to the board. And after that, the state of Arizona decided they needed some regulations concerning office-based surgery. And there was a lot of focus on having an emergency response plan, making sure that you have drills with your staff, making sure that you have a transfer agreement with a facility. So all these things need to come into play because we had been hearing about facilities, office-based setting, where their emergency plan was just to call 911, and that's not a good enough plan. So the patient selection, this is the surgeon's liability exposure or surgeon's responsibility, and they're primarily responsible for the aspects directly related to their scope of practice. So this means the surgeon must ensure that the patient is a suitable candidate for the procedure by conducting a thorough medical history, review, physical exam, and necessary diagnostic tests. So if the surgeon fails to perform these duties adequately, they can be held liable for any resulting complication or adverse outcomes from the administration of anesthesia. So you definitely want to evaluate, what's our criteria for ASA class? We need clearance from other providers, from their endocrinologist or the cardiac physician to be able to do this procedure. Do we need to hold any medications? If somebody's on blood thinners, when should we hold these and when should they restart? I've seen exposures related to that too, when patients aren't aware when they should stop and when they should start. So they need pre-op instructions and then also post-op instructions that are clear. So sedation level and type, so depending on the procedure and patient needs, you may use local, regional, ASC, you're not using general, but the choice of the sedation will be determined by the surgeon and the anesthesiologist. And this is important. It should be a discussion between the surgeon and anesthesiologist. It shouldn't just be the anesthesiologist's choice. And it's based on factors such as the patient's medical history, the complexity of the procedure, patient comfort, and the goal is to provide adequate sedation while ensuring patient safety. So you look at the ASA class, how long is your procedure, you're going to use oral or IV sedation, and the continuum depth of sedation. And oftentimes it's discussed that, sedation is a continuum, and sometimes patients can fall into a deeper level of sedation and need to be aware of that and how to get the patient have the right emergency equipment and medications to reverse that. So anesthesia administration, if you are responsible for the supervision, I would consider ACLS certification. It's a one-day course. Also having your providers, either a CRNA or an RN, have that. Ensure strict credentialing, privileging, and training of anesthesia providers, making sure that they have performed the blocks if they're going to be responsible for the blocks, that they have the ophthalmic anesthesia training. You want to make sure you report any patient safety concerns immediately that you have with the anesthesia providers, whether it's to the ASC administration or you yourself are responsible, that you take action immediately. Include the anesthesia providers in any emergency drills. Everyone should know what their role is, who does what in an emergency, and these should be simulation drills that you do on a quarterly basis so that it's very clear what everyone's roles are. So courts do generally focus on the degree of control the surgeon exercises over the anesthesia provider when they're looking at liability. If the anesthesia provider operates independently and uses their own independent judgment in the administration of anesthesia, the surgeon isn't held liable for the anesthesia provider's actions. However, if the surgeon exercises significant control over the anesthesia provider's actions, there may be a potential for liability. So again, with the supervision of the CRNA and the RNs, based on how that regulation plays out, also can affect the potential exposure that the surgeon has. And one thing, there should always be a licensed healthcare provider responsible for the monitoring the patient while the surgeon performs the procedure. And we get calls on this sometimes, and this is really important. The surgeon has to focus on the surgery and cannot be focusing on monitoring the patient. So you need to have at least a registered nurse, a licensed healthcare provider that is monitoring the patient. And it shouldn't be an ophthalmology tech or a medical assistant. It should be someone who's licensed, like an RN, to monitor the patient. So despite all precautions, emergencies can occur, and the facility should be equipped with an emergency response team trained to handle any complications swiftly and effectively. This team includes the anesthesiologist, the anesthesia providers, the nurses, any other medical professionals who are prepared to provide immediate care. You should have emergency equipment and medications readily available to manage the situation. Should definitely have an ACLS certified healthcare provider on the staff. Would consider, as a surgeon, if you are supervising, that you also have the ACLS certification. This isn't something that's a written requirement anywhere, but it's a good idea. It's a risk recommendation. Having emergency drugs available, resuscitation equipment, including a defibrillator, oxygen with a monitor, cardiac monitor, having electrical generator in the event of power failures, having a policy and procedure in place for emergency protocols, and then a transfer agreement with a hospital. Those are all important to have. So now I'm going to go over some case examples. The first case involves a death in the ASC. Now this is a non-ophthalmology case, but it highlights how an anesthesiologist can also result in exposure for the surgeon. So this happened in Portland, Oregon, and just recently a jury returned a $25 million verdict for a death following a colonoscopy. So this was in an ASC, moderate sedation, doing a routine procedure, colonoscopy. The allegations in the lawsuit were failure to react to the patient's crashing vital signs, failure to resuscitate. Patient had a history of sleep apnea, also had a high BMI. Allegation was that the procedure should not have been performed at the ASC, should have been done in a hospital setting because of the patient's ASA. There was no training at the ASC for how to respond to an emergency. The patient was without oxygen for 22 minutes, which led to brain death. So the anesthesiologist actually settled before this case went to trial. The anesthesiologist actually surrendered their license as well. There was no, I'm not sure what the backstory was with the anesthesiologist, but this anesthesiologist had the majority of the negligence in this case. But when it went to trial, in the jury verdict form, they list all the potential defendants, even defendants that settled out. So on the verdict form was the ASC, which includes the facility liability and staff. So they had a scrub tech and nurses. The anesthesiologist was listed as a non-party because they already settled. And then the physician, in this case, it was the gastroenterologist who was performing the colonoscopy. So they allocated 40% of the verdict to the ASC and then 60% to the anesthesiologist. So it would be reduced by the amount the anesthesiologist was allocated because they already settled out. Interestingly, the physician did not receive any liability exposure. So in this case, the physician got dragged into the lawsuit, but the jury found that they were not responsible for the errors and omissions on the part of the anesthesiologist. But the ASC was, because they had staff that was involved in delays of responding to this respiratory event. Now in Oregon, there is a $500,000 wrongful death cap, but it's currently being challenged as unconstitutional. So it remains to be seen whether this verdict will be reduced. But this case just highlights, yes, as a surgeon, even if you have an anesthesiologist, doesn't mean you're in the clear. You still have to be, you're still responsible for patient selection criteria. So contributing factors in this case included the patient was ASA 3 with sleep apnea and a high BMI, was not a candidate for the ASC based on what happened. There was poor communication among the team. There was a failure to stop the procedure when the respiratory complications occurred. The anesthesiologist failed to call a code when manual ventilation was initiated. It was actually the scrub tech that called the code. There was a failure to respond properly to the respiratory distress. So the physician didn't realize all this was going on. And so they didn't alert the physician. And there was delays in the staff speaking up. Like they saw what was going on, but the anesthesiologist was like, no, it's fine, it's fine. So they should have spoken up. And then there was a lack of emergency response plan, training, and drills. So the staff was unprepared for how to handle an emergency. So this was a very unfortunate case. So risk recommendations should definitely identify high-risk patients in the pre-op assessment. If they're not a candidate for office setting or ASC, don't make exceptions. Conduct an OR team briefing and debriefings to discuss the plan, any potential complications that might come up, team roles. You definitely want to foster a culture of safety that empowers staff to speak up with safety concerns. So in this case, the staff was timid about speaking up. They didn't communicate to the surgeon what was going on. The anesthesiologist wasn't communicating. So it's really important to foster that culture of safety, have protocols to immediately stop procedures when there are respiratory complications, develop a comprehensive emergency response plan for various types of emergencies. So not just respiratory distress, but there's other emergencies that can occur. Make sure all team members know their roles, and then conduct emergency drills to ensure staff are familiar with the emergency response plan and execution. So during the trial, the staff did say that they had no idea how to respond to an emergency, and their roles and responsibilities were not clearly laid out. The second case example is a bilateral blepharoplasty procedure, and in this case, patient received IV sedation, nasal cannula, cautery, alcohol-based skin prep, and a surgical drape was used. So as the surgeon used the electrocautery to coagulate the bleeding, a flash occurred and the surgical drape ignited, resulting in second-degree burns to the patient's face. So in this case, the lack of communication was a contributing factor during the procedure. There was an insufficient timeout to assess the fire risk or to perform a workflow verification step or safeguard. So this is something we recommend having in your surgical safety checklist is, okay, recognize that there's a potential fire risk. And those risks were related to the 100% use of alcohol. It wasn't allowed to dry, so that was a fuel source. The use of 100% of oxygen, that's an element in the fire triangle, and then poor training or failure to use proper precautions when using electrosurgical devices like cautery. So a fire triangle includes ignition, fuel, and then oxygen. So in this case, the ignition was the cautery device, the fuel was the undried alcohol and the surgical drape, and then there was oxygen. So there should have been discussion with the staff about this fire triangle and this potential for having an OR fire. So it's really important to have fire safety discussions in the surgical safety checklist or briefings before the start of the procedure. The American Society of Anesthesiologists ASA Task Force on Operating Room Fires Practice Advisory states that surgeons should inform anesthesiologists before using a potential ignition source, and the anesthesiologist should inform surgeons if there is a potential for an ignition source to be exposed to an oxygen-enriched environment. You should implement protocols to verify that the alcohol prep is dried before using any ignition sources. You want to stop or reduce the delivery of oxygen to the minimum required for at least 1 minute before using electrosurgical devices. If the patient requires oxygen greater than 30%, consider alternatives, such as an endotracheal tube or a laryngeal mask airway. And then educate all surgical team members about the elements of the fire triangle and the conditions that can lead to a surgical fire. And conduct regular fire drills and simulation to ensure all staff are prepared to respond to a surgical fire. The third case example involves an anesthesia-induced brain death, and this was a planned cataract surgery at the ASC. The patient's comorbidities included kidney disease and diabetes. Patient did receive clearance from their PCP and nephrologist, but there were some labs pending that did not get resulted before they proceeded. Patient's IV sedation was Versed, fentanyl, and propofol. This is for cataract surgery. And within seconds of the administration of the anesthesia, the patient suffered a respiratory arrest, followed by a cardiac bradycardia. Monitoring devices were used, but no CO2 monitor was used. The anesthesia was administered when the surgeon was not in the room, and then the patient ultimately was confined to a surgical nursing facility for the remainder of their life. So in this case, the anesthesia provided was Versed, fentanyl, and propofol within immediately. The patient had respiratory arrest. 911 was called right away. The patient was intubated. There was delay in the intubation, delay in CPR beginning. Paramedics arrived 6 minutes after the code was called, and then by 8 o'clock, patient had no vital signs. So even though the timeline might sound like it was handled appropriately, there was still delays that led to the brain death of this patient. So in this case, the surgeon had actually relied on the anesthesiologist to determine the sedation medications, and it should have been a discussion with the surgeon anesthesiologist. There was no discussion, and if you're doing cataract surgery, you really didn't need the heavy doses of sedatives that were given to this patient, especially considering the kidney issues that the patient had. It was contraindicated to give that much medication, and they could have just used local anesthetic. The surgeon should have been in the room when the block was delivered by the anesthesiologist. They felt the patient shouldn't have been draped, which likely led to a delay in the recognition of the respiratory distress. And there was a failure to address in a timely manner the distress. So risk recommendations, again, thorough pre-anesthesia evaluation. There were some pending labs that had not yet been resulted, and yet they still proceeded with this procedure, with this high-risk patient. So again, that's typically when we see liability involving anesthesia, the surgeon can get brought in if this pre-risk assessment, pre-evaluation of the patient is considered negligent. You also want to have clear communication between the surgeon and the anesthesiologist to discuss and agree on the sedation before the procedure, document the discussions and the decisions made regarding the anesthesia, implement stringent monitoring protocols during the procedure, conduct regular emergency drills that include anesthesia. And the fourth and final case, this was nerve damage from a CRNA block, and this was cataract surgery at the ASC. CRNA administered a retrobulbar block. The block needle was inserted into the optic nerve, and then permanent nerve damage and vision loss resulted. And the CRNA surgeon and ASC were named in the lawsuit. In this case, the CRNA was under the surgeon's supervision. So contributing factors, the initial block produced inadequate anesthesia, which necessitated the need for a second attempt, and that second attempt increased the risk of complications such as blood penetration and optic nerve injury due to the increased volume. The anatomy was distorted. The CRNA punctured the optic nerve with the needle. CRNA lacked the adequate level of training and skill and competence to administer this block safely, and the surgeon should have suggested a blunt cannula inserted for the second attempt. So risk recommendations, consider if you are making a second attempt, a blunt cannula due to the volume issues. Ensure anesthesia providers have adequate training and competence for ophthalmic specific procedures. Make sure there's adequate credentialing and privileging by the ASC for anesthesia providers used in ophthalmic procedures. So if you are doing these blocks, they should be well versed in those blocks. So finally, in conclusion, you want to develop a policy. This is in conclusion for the whole presentation. Develop a policy on pre-op assessment, which includes patient selection. So as you can see, that's a major liability risk when there is an anesthesia event that can bring the surgeon into litigation. Establish strict credentialing, onboarding competency, and evaluation of anesthesia providers. So in the office setting, this is something the surgeon can be exposed to because you're the one credentialing and privileging that anesthesia provider, making sure the provider has adequate education and training. You're also likely supervising that anesthesia provider if you're using an RN or a CRNA that might require supervision, but you have more control, especially in the office setting, of what is going on with the anesthesia. And that's what courts look at. The more control you have, the more exposure you might have when there's an anesthesia event. You want to develop a policy and procedure for sedation administration, conduct OR team briefings and debriefings to discuss the plan, any potential complications that might arise, the team roles, and then definitely use a surgical safety checklist, especially when you have potential things like fire triangle. Require a licensed healthcare provider to monitor the patient while the surgeon performs the procedure. This should not be compromised on. And then develop a comprehensive emergency response plan to make sure that everyone knows their roles and responsibilities when there is an emergency to mitigate risks. So that is all I have, and this is our references, the various references, and I appreciate your time listening. Thank you.